Good morning, everyone. Welcome to today's webinar entitled Changes in HPV Testing at Colposcopy. My name is Dr. Donna Turner. I'm the Chief of Population Oncology at CancerCare Manitoba, and I'll be your moderator for today's session. So before we start the webinar, we've just got a couple of sort of administrative or housekeeping things that I'd like to go through with you. So I think they're on the next slide. And so the first thing is that the webinar is going to be available for viewing after today, and you'll within a week of the webinar, it'll actually be up on CancerCare Manitoba's website. So if you want to have a look at it and review something or share it with a colleague, you have that opportunity in a very short period of time. The second thing is that the last 25 minutes or so of this webinar are actually dedicated to you to ask questions that you might have of Dr. Kean and Laura Coulter, who is the screening manager at the screening programs at CancerCare Manitoba. What we're going to do for that is, instead of using the chat, we're going to use the Q&A box. So if you look at the bottom of your screen, you'll see a little box that says Q&A with a question mark in it. If you click on that, you can type your question, and then we will be able to manage those, and we'll ask those questions. So you put the questions in the chat, and I'll go through them, ask them, and Dr. Kean or Laura will answer your questions. So just a reminder, Q&A, not the chat. All right, so let's get going. So as we do, we're going to start with the land acknowledgement. I want to note that CancerCare Manitoba provides health services across Manitoba on the traditional lands of the Anishinaabe, Inninewak, and Anishinaabe, Dakota, Eote, and Dene peoples. We acknowledge that Manitoba is also located on the homeland of the Red River Métis, and northern Manitoba includes lands that were and are the ancestral lands of the Inuit. CancerCare Manitoba acknowledges that colonial practices and policies have impacted the health and well-being of generations of First Nation, Métis, and Inuit who continue to experience inequities and obstacles in accessing healthcare, including cancer services along the cancer continuum. At CancerCare Manitoba, we respect the spirit and intent of the treaties and treaty making, and remain committed to working in partnership with First Nation, Métis, and Inuit peoples in the spirit of trust, reconciliation, and collaboration, while also improving cancer control and outcomes for all Manitobans. One thing I want to note in terms of a personal reflection, which is important when we say the land acknowledgement, is that for me personally, to make a small gesture of respect for the Indigenous lands that we're on and its people, and that I recognize that I personally continue to have advantage and opportunity while others have been and still are disadvantaged. I take my role as a member of CancerCare Manitoba's executive leadership team to work and engage and respond to Indigenous voices in cancer care planning, service delivery, and evaluation. And I also look for ways to continue to educate myself along the way. It's a long journey that we are all on together. All right, so after that reflection, let's go to the first slide, and I am going to introduce to you Dr. Sarah Kean, who is the CervixCheck medical lead. Dr. Kean is going to provide the overview of HPV and explain how the HPV test of cure will benefit your patients in colposcopy. So with that, over to you, Dr. Kean.
Okay, just got to make sure I'm unmuted. All right, thank you, Donna. Okay, and in the interest of the land acknowledgement, I always like to highlight the importance of this because of the work that I do. And I think that cervix cancer really still highlights the inequity that is present in our province. And I work every day to advocate and try to overcome this. Part of the work in HPV testing is with a critical goal of addressing some of this inequity. And so with that, I like to point out that this is a national effort as well. It's not just me. And CPAC is the Canadian Partnership Against Cancer. And in our pillars of eliminating cervical cancer worldwide, there is a strong commitment to First Nations, Inuit, and Métis people. And you can view this on their website as well. But addressing culturally appropriate care close to home has to be one of the most critical pillars, and equal care close to home. So for me, this is also similarly very personal. And I encourage you guys to read about this a little bit more, what our actions are, and see that unfold hopefully in our province in the very near future. In that lens, we have a little microcosm here in Manitoba with striking health inequity, but internationally, cervical cancer remains a reflection of disparate access to care across the globe, and is really represented in our province as well. So this quote really speaks to me, saying that more than any other cancer in the world, cervical cancer reflects striking global health inequities. And that is, again, part of the reason that we do this work. Part of the reason why it demonstrates the inequity so much is because it's entirely preventable. And so along the journey today, we'll talk a little bit about how we can work towards eliminating cervical cancer in Manitoba as well as internationally. So we're going to talk about HPV testing that's available in Manitoba. We're going to talk about upcoming changes to HPV testing and application of test of cure, which is our new test that is available. I wouldn't do a presentation on HPV without talking a little bit about the pathophysiology and practical applications. And of course, always a note on vaccination, because it's one of my favorite things to talk about. In terms of disclosures, I am enrolling patients in trials run by some drug companies, and I have patients in follow-up from trials as well. I do not have any financial benefit from these, but my patients do stand to benefit from access to these trials. The other thing I'm going to mention is that I will discuss potential off-label use for non-availed HPV vaccination. I will tell you when it is the off-label use in the course of the presentation. So, and so I alluded a little bit to this declaration of elimination, which is kind of not even the beginning of our journey, but really an important international stepping point. And in 2020, the World Health Organization said essentially, nobody should suffer from cervical cancer. This is something that is completely eliminatable, and we're going to do that. So 194 other countries joined that call and are working towards actionable items to eliminate cervix cancer. And so the threshold for elimination is 4 per 100,000 women as a public health problem. And it really relies on 3 critical pillars that each country is going to try to achieve. Initially, our target was 2030, but as you can tell, we're more than halfway there from 2020, and we really still have a lot of work to do. So that target has been moved back a little bit towards 2040. And so this is CPAC, again, the Canadian Partnership Against Cancer, and they really designed their pillars with Canadian healthcare systems in mind and Canadian values to try to extrapolate from the World Health Organization's recommendations. And so priority number 1 is improving HPV vaccination rates. Initially, the target was 2025 of 90% of 17-year-olds fully vaccinated with HPV vaccine. And I always forget the most up-to-date stats. I think it's somewhere around 70%. So you can really see that we're nowhere near that mark, with our target being this year. So there is a lot of work to do around vaccination. And again, we'll talk about vaccination towards the end of the presentation. And we'll talk about some practical ways that we can work together to improve this. Implementation of primary HPV testing. So that is saying that everybody who presents for cervical cancer screening is offered an HPV test, with a target of 90% of eligible individuals up to date with screening. And I can tell you that we're not there either. Similar numbers, I think around 68 to 70%. And offered HPV testing rather than Pap testing. And currently in our province, the bulk of the screening is being done through Pap testing. And so there is work to be done there, which is ongoing for sure. And then priority number 3 is improving follow-up of abnormal screening, with 90% of all individuals with a positive HPV test being seen in colposcopy within 3 months of the results. And we do a pretty good job at that. CervixCheck, for which I can take no credit, it's all the staff that work with me, do a lot of work in reaching out to abnormal PAPs at this point, and helping ensure that people get to where they need to be. And so what is quite shocking is, in light of an eliminatable disease, which we should be making progress on, we're actually seeing the inverse. And so this is courtesy of Dr. Turner and the Department of Epidemiology and Cancer Registry. And what we're seeing is, in fact, a sharp uptick in the incidence of cervical cancer in our province. And myself and my colleagues were actually saying this for years, saying, oh my, what's going on with all the cervix cancer? There's so much, it's so much advanced disease. And then Donna kindly shows me this slide, and I'm glad to know that I'm not losing my marbles. But what we saw over decades is a very sharp decline in the incidence of cervical cancer. And then kind of around 2018, a very sharp uptick in incidence here. And this predates COVID, so we can't blame COVID on all of this. This is also not Manitoba. We're seeing this across the country and internationally in terms of increasing incidence of cervical cancer. And anecdotally in our province, we're seeing more advanced disease. And so there is, like I said, a lot of work that needs to be done here to address some of these pillars to try to reduce this incidence in something that could be completely prevented. This is my favorite graph to talk about when I'm talking about HPV. And I just like to go through it because it really nicely highlights the kind of natural history of HPV infection and why we make the decisions that we make when it comes to screening. When we moved to 21, even for PAP tests, there was a lot of discomfort with that because, well, we've always done them manually and we've always started as soon as people want birth control or start having sex. But the evidence isn't there. The evidence really suggests that we don't need to be doing that. And I like this graph for its simplicity in demonstrating that. It does make a few assumptions, which I will point out along the way. And assumption number one is that, most people in a global patient population would start having intercourse somewhere between 15 and 20. And as people start having intercourse or relations with other people, then the incidence of HPV increases really dramatically in a patient population. What's important to remember here is that, yes, HPV is sexually transmitted, but at its heart, it is a virus that is spread by skin-to-skin contact, which of course sex is skin-to-skin contact. But all that has to happen is skin-to-skin contact for transmission of HPV. The other thing is that this graph really undersells how prevalent it is in the patient population. We've got studies that say 85 to 90% of the patient population. But I think more accurately, if anybody has been sexually active, you have to assume that you have encountered an HPV virus of some description. And so as this patient population starts to increase sexual activity or skin-to-skin contact, then we have a huge incidence in HPV infection, which makes sense. With time, most patients will clear their HPV, and so the incidence in the patient population will start to decrease. A lot of patients will also start to form monogamous relationships and not be out there encountering new HPVs necessarily. And so the patient population infection rates will kind of come down to this basal level here, where it doesn't approach zero, but it is a steady kind of level in the patient population. The first interesting thing to note is that the incidence from peak HPV infection to the incidence of peak precancer is about 15 to 20 years. And so this gives us a long lag time where we can really safely start screening without causing harm. And then if you look at the incidence again from precancer to cancer, you're looking at about another decade. And so because the way that HPV typically behaves is this long lag time, this long drawn out infection without any adverse consequences, then we really have a lot of opportunities to intervene. And this is one of the main reasons why every 3-year screening is really quite safe, because even, starting at 21 here until the incidence of cancer, you have several opportunities to intervene in terms of screening and treatment before we have a problem. This graph really also nicely demonstrates why we don't want to start screening as soon as people start having sex, because we're going to catch all these people, and these people are not the ones that we want to be screening. If we were screening everybody with a new HPV infection, the system would be completely overwhelmed, and we know this is safe to avoid doing. So really the ideal time to start screening is here as this curve starts to drop down, decreasing incidence of HPV infection, and then we're truly starting to catch those that have have persistent infection. So I hope this makes sense. A few facts about HPV. Most people clear their HPV. So all of the people in this graph who get this infection, 90% of them will clear it on their own. And the younger you are, the more likely you are to clear an HPV infection. And so again, we don't want to be screening these people at all. Interestingly, it'll come up a little bit more when we talk about vaccination. HPV is cleared by cell-mediated immunity, and it can take quite some time. But because the immune response that you get with cell-mediated immunity is not robust, the immune response you get from vaccination is actually much better. 90% of women will clear this HPV infection within 2 years, and all comers, not just women. Male partners will also clear the HPV infection within 2 years. The most important thing here, though, is that the only thing that causes cervical cancer is persistent high-risk infection, and you have to have both of those features. So you have to have a specific strain of HPV that is considered high risk and has oncogenic potential, and it has to be persistent. So if you're in one of those cohort at the beginning that has the peak incidence and clears it, you're not really at risk. And so people that have high risk infection that clear it right away, there's no cancer risk. People that have a low risk infection, which is going to be the vast majority of HPVs out there, have really no malignant risk at all. And so our screening programs really need to target those that only have this high risk HPV. The type itself is the strongest factor that's affecting persistence and progression. And HPV 16 is the real bad guy. And that has an absolute risk of CIN3 of about 40%. But even that, if you have HPV 16, you have CIN3, you still have a reasonable risk of regression and clearing the HPV and reversing the precancer changes. That said, we often will treat everybody with precancer just because when you're looking at something at one point in time, it's very hard to know if this has been persistent or if it's a new infection. And we like to have a healthy margin of error when it comes to preventing cancer and treating at-risk individuals. So that brings us to HPV testing. And so right now in that algorithm, we're looking for abnormal cells. So the Pap test is taking a sample of the cells on the cervix and looking for any abnormalities. What HPV testing does is it really takes a step back in that algorithm. And instead of waiting until somebody has abnormal cells, we're looking for presence or absence of the virus. And this lends itself really well to a couple of advantages when it comes to screening. It's much more sensitive than cytology. And part of this is because it's very objective. And so we're testing for presence or absence of high-risk HPV DNA. So it's using PCR, and you do the PCR and the machine basically gives you a quantifiable value. Whereas cytology, you're looking at some cells under a microscope and deciding whether or not those are abnormal or not, and what degree of abnormal. With absolutely zero shade to my pathology colleagues, I think they're incredible, but there is room here for human error. Certainly there's still room for human error in PCR, but it is a more objective test and more sensitive when it comes to detecting high-risk virus. The other thing that cytology does is it can't differentiate between high-risk virus and low-risk virus. So if somebody has LSIL, you don't know if that's just low-risk HPV that really has no malignant risk, or is there something bigger going on there. It's more reproducible for all those reasons. You have greater protection against adenocarcinoma as well, which is kind of the big failing of the Pap test. If the lesion is higher up in the canal and you happen not to catch it with a Pap test, then you may be waiting until the adenocarcinoma is larger before it's detectable. Whereas HPV testing, if the virus is present, the virus is present. And so somebody would be brought into a colposcopy clinic earlier if they're having AIS or adenocarcinoma than if you were waiting for a visible lesion. In all the studies, we actually see a reduction in specificity when it comes to HPV testing. And in my mind, this is actually a really good thing. The reason for this is because the trial outcomes, still looking at the validity of HPV testing, we're still CIN3 because that's the easiest measurable target. And not everybody that gets an HPV infection is going to go on to get CIN3 or invasive cancer or death. And because you're taking a step back in the algorithm, less people are going to achieve that final outcome, which is where it looks like you lose in specificity. What you're still doing, though, is identifying an at-risk patient population and bringing them in for increased follow-up. And so in my mind, I don't think that's a bad thing at all. In fact, I think it's a good thing because we're also selecting out those who have low-risk HPV and don't need to be seen in colposcopy. So it balances out well, I think. When it comes to HPV testing, there are a couple of different ways that we can use it, and we're kind of slowly working towards primary HPV testing in the province. In 2022, we brought out triage, so I think most of you are probably familiar with triage. And people who have these low-grade abnormalities, we're looking to see who really needs to go to colposcopy, who doesn't. And so it'll be reflexively tested for HPV on those low-grade PAP results. And that if there is persistence or if there is presence of high-risk HPV, then they'd be sent directly to colposcopy. If there's no HPV, even if they have LSIL or ASCUS, then they return to routine screening. And again, this is because if there's no high-risk HPV, there's really no malignant potential at all. And so we are very confident in sending people back to 3-year PAPs instead of making them come back again at 6 months or an earlier interval. What we're going to focus on today is test of cure. And so this is new to our province. We started it in the new year. And we're using this exclusively in colposcopy at this moment. But it's another important stepping stone to getting people out of colposcopy clinic when they don't really need to be there and moving forward towards our goal of primary HPV testing. And so we'll talk a little bit more about this, but essentially its goal is to determine success or failure of colposcopy treatment. So if somebody has precancer and they're treated with a LEAP or the laser, to make sure they've cleared the HPV on the other side of that treatment. We're also using it as a exit strategy when it comes to HPV triage, because what we found is, although this is excellent and it reduces some of the people that need to come, we do have a cohort of people that got into colposcopy with a high-risk HPV, and we just don't know if they've cleared it or not. And so this gives us kind of an exit strategy for those people. If you come in with positive HPV, can we discharge you with assurance that that is gone? And so we're using this test of cure in both of those strategies. And so I just am going to talk through the literature supporting this a little bit without getting into too much detail, but it is well supported in the evidence. The initial trials were smaller and kind of predated this, like 2015, 2016. But what I like with this is that this is really clearly demonstrating the benefit. So this is taking a patient population in that post-LEAP. So they've all had high-risk HPV, precancer, high-grade dysplasia, and then been treated with it. And then in follow-up, this is kind of how they investigated. And so you could look at the margins on the LEAP cytology as well as HPV, or margins in HPV alone. And then they looked at other options as well here. And so when you do a LEAP, you get a little piece of tissue that goes to the lab, and they look at it under the microscope, and they will comment on the margins. And so if the margins are negative for high-grade dysplasia, so it looks like you've excised the entire lesion, and you have HPV negative, you can very, very well predict cure here with a negative predictive value in this study of 100%. And so it's really excellent data. If you use cytology as well, it helps. But later in the study, they described that if you're using cytology, you actually have a little bit more propensity to keep people, because if you've got a really mild abnormality that's inflammatory or something like that, then you may see a mildly abnormal PAP. But you can really be assured when you see negative margins and negative HPV that somebody is good to go. And so in my practice, when I see people post-LEAP, I don't do a PAP, I do margins, and I look at the HPV status, and it is quite reassuring. This is, again, just the algorithm that they used in this study. So if people are HPV negative, immediately they are returning to screening. If somebody has a positive margin but is HPV negative, I probably would still discharge them, but with a note of caution, perhaps. After you do the LEAP, you use the cautery machine to, make sure there's no bleeding, and you will destroy still a little bit more cervical tissue. So if their HPV is negative, I think it's quite reassuring that they truly have cleared the virus. If HPV remains positive, then this patient population would be kept in colposcopy. So typically now, or pre-test of cure, what we would do is 2 colposcopies. If they had PAP negative, everything looks okay, then we'd say, well, it's probably fine and you can go. This is a much better test, again, because you're really clearly stratifying those who are still at risk for persistence or recurrence of high-grade dysplasia versus those who really have no risk once they've cleared the HPV. Some of this data was reproduced in Canada, which is always nice to look at. So this was published in 2017 with 2,300 women. So this is a really good sized cohort, and almost 2,000 high-risk HPV negative women. And only 1.9% of them had a subsequent diagnosis of CIN2+. And of course, what this trial can't control for is, did somebody go and get another HPV? Is this reflective of recurrence of the initial infection and pre-cancer, or is it a new infection? And unfortunately, that's never going to be answerable in a trial like this. But again, a negative predictive value of 98.1% is really quite a good test. And then more contemporarily, which I can't believe 2017 is not that anymore. This was a big trial published in Gynae Oncology, which is kind of our really big journal, with 11,000 women with CIN3 on cone, followed for 14 years nationally. And these curves are really nice. And so this group over here is your HPV negative women, and these are your persistently positive women. And then the margin negative is the red dot, and margin positive is the blue line. And you can see really how all of these factors, both HPV negativity as well as margins, really stratify themselves quite nicely. And so the patient population that has HPV positive persistence as well as a positive margin, we're looking at 20% risk of recurrence of precancer or more. And then here in this HPV negative women with negative margins, similar numbers to what we saw in the Canadian study, so about 1.3% risk of recurrence. So this really is a good test when it comes to stratifying risk post-treatment. Just as a little bit of a segue here, I wanted to talk about some more Manitoba specific data and what we're seeing. In our journey towards working on HPV primary testing for everybody, we've collaborated with CPAC, and they have this fascinating tool called OncoSim. And so what it does is it basically models what your patient population will look like, and they take all kinds of factors like ages of the population and current screening incidence and vaccination rates and all these things, and kind of project what things will look like when you move forward with primary HPV testing, depending on the algorithm that you pick. And so this is what they have given us, and one of them output measures, which I think is really interesting and important to know, when it comes to decision makings around moving forward with primary testing. And basically what this is saying is when you first start doing primary HPV testing, you're going to have a huge peak in the incidence of referrals to colposcopy. And so this gray line here is status quo. If we kept going with Pap testing, this is kind of how our referral patterns would go. And then this jagged line is if we switch everybody over to HPV testing at the same time. And this, again, makes a lot of sense if you think about the natural biology of HPV. And so, right now we're picking up these people that have cytologic abnormalities. As soon as we switch tests, take that step back in the algorithm, you're going to grab this huge cohort of people that don't have an abnormal Pap, but do still have positive virus. And so a lot of data, not just the OncoSim data, but internationally, shows that the first 5 years of transition to a screening program, you have a huge peak in the incidence of referral to colposcopy. And so this really was one of the driving forces behind Test of Cure as well, is, if we can now start to kind of filter out those lower risk patients and take them at a colposcopy clinic sooner, that hopefully the impact of that big peak is going to be lessened a little bit when it comes to transitioning to primary testing. The other thing, this looks very dire, but it's also assuming that literally everybody shows up on the day of their birthday to come and get their HPV testing. And we all know that's not the reality. And so this will probably, both of these will average out a little bit over time because of, patients, when they come, and it won't be quite so dramatic as this. But there's certainly, we expect an increased incidence of colposcopy referrals kind of between now and when we start primary HPV testing. And so this is just one of the algorithms that we're using. So if somebody has an excisional procedure, either a LEAP or a laser, we see them at 6 months. They get a test of cure that is done with an HPV test. If they're negative, we will send them back to primary care for routine screening right away instead of that second visit. And if they're positive, you would expect them to be kept in the colposcopy clinic really until they clear that HPV. And we'll see them every 6 months to a year, depending on the colposcopy, and repeat that HPV testing until it is negative, or until they recur with their high-grade dysplasia. And so you can be reassured in primary care that somebody who is discharged back to you is less likely to have a recurrence of their high-grade dysplasia. And this is similar. Kind of the other arm is, people who came in through triage, and then we also briefly had that self-sampling project where people came in with a positive HPV test as well. So if people came into colposcopy with triage, if they have negative HPV test at discharge, then they can go back to routine screening. And if they remain HPV positive, they're going to stay here in colposcopy clinics rather than being discharged out of colposcopy. So that's what you can see there. So how have we approached this? So we had a soft launch in January with just a few colposcopy clinics, just to let the lab get used to the higher volumes and up and running with things. In full launch February 1st. So all colposcopy practitioners in the province have access to doing this test. It is only accessible to colposcopy, and if it is done outside of the specific list of colposcopy providers, the test will be rejected. So unfortunately, I know so many people want this. I get emails and phone calls and Tiger Connect messages literally every week saying, hey, can I do this for this person? This person really needs this. And when's it coming? We're working on it. But for now, if you are not a colposcopist, unfortunately, you can't do this. And so it has started, and we wanted to do this webinar to let you guys all know what we're up to. When it comes to follow-up, what we have decided is that even though I am very reassured that a negative HPV test is reassuring, we didn't want to completely revamp the CervixCheck screening guidelines and then do it again when we move forward with HPV testing. And so in the interest of not confusing everybody, we're still going to recommend that if somebody has had high-grade pathology, if they've had a LEAP or a laser, CIN3, HSIL, anything like that, that I would still screen them annually after they're discharged from colposcopy, even if they're discharged with negative HPV. If they never had that high grade, so if they come in through the triage algorithm and then we don't really find anything, then I would go back to every 3-year screening. And in that patient population, it's certainly reassuring. In fact, when we move with primary HPV testing, we're going to be looking at a 5-year interval. And again, the data on HPV testing is so reassuring that this is okay. So a negative HPV test is basically the most reassuring thing you can get when it comes to lower risk of cervical cancer over the next 5 years. So don't change what you're doing now. If somebody had high grade histopathology, continue to offer them annual pap testing. If they have not had it, if they're discharged, go back to every 3 years. And we should still be indicating that on the colposcopy form when people are discharged. Okay. So that is what I have to tell you about HPV test of cure. Like I said, there'll be lots of time for questions. I just have a few notes on vaccination because I love talking about vaccines. Okay, so in our province right now, we have a few ways to access HPV vaccination. The school-based program is currently offering vaccine to females born on or after January 1st, 1997 and males born on or after January 1st, 2002. This is offered in grade 6, and we have in our province a once eligible, always eligible policy. So what that means is if somebody didn't get their vaccination in school, that it still would be considered free for them for the rest of their life, basically, as long as they meet the criteria. And so this, and the kind of, we'll go through the stuff beside it. This is one of the reasons that I think that primary care is so critical when it comes to improving vaccination rates. We can only do what we can do in the schools. And if somebody says no, or the parents didn't do the permission slip, or the kid is sick on the day of vaccine day, there's a lot of pitfalls when it comes to vaccinating in school-based cohorts, but most of these patients are still going to have access to primary care and can be vaccinated in a primary care clinic still free of cost. And so primary care clinics, I'm sure most of you know this, but can stock HPV vaccine in your clinics the same as you access vaccine from the warehouse for COVID or flu. And you can vaccinate liberally for anybody who meets the criteria. So anybody who meets these age-based criteria, if they've not been vaccinated, then please go ahead and vaccinate. The CervixCheck Cancer Registry, if people are over 18, will have vaccination data, but we don't have that on the younger cohort. But the Panorama, I think, should. Not that I know a lot about that. And then we have this other eligible cohort for free vaccine in our province. And so essentially this boils down to people that are at increased risk of getting HPV or of having severe consequences from HPV infection. And so the vast majority of what I do is hang on, I'm using the wrong screen. This one right here. So females aged 9 to 45 years of age who have a newly diagnosed high-grade histopathology. Basically, anybody who comes to my clinic and gets a LEAP leaves with a vaccine. And we've recently been able to shift our nursing so that they can vaccinate people. So they literally get their LEAP, they get their vaccine, and they go out the door. And then they can come back for subsequent doses. Previously, I was having to do prescriptions, and I had a little stamp that says patient qualifies for a provincially funded vaccine. But even pharmacy sometimes presents barriers if they don't have vaccine warehouse stock and they're using their purchase stock, or if they don't know about these criteria, then some patients were being asked to pay for it. And so again, if primary care or anybody on the ground can be offering this, I think that is the best way to increase our vaccination rates. The other thing here is anybody who is a victim of sexual assault with really no sort of time rider on there. And in primary care, so many patients are going to be disclosing to you and nobody else. And I think that if you think somebody qualifies for vaccination under these bigger criteria, then please just do it. It doesn't have to be a police reported assault or anything like that. They don't have to prove it or defend themselves anywhere. If you think somebody qualifies for vaccination, then please do it for people. I kind of alluded to this earlier that the vaccination immunogenicity is really, really excellent. And it's better than anything we see from natural infection. And so even in somebody who's been sexually active in the past, there's still value. I mean, we've got good data that even in somebody who has high risk HPV and high grade dysplasia, there's still value in vaccinating them. So literally anybody who meets criteria really should be offered vaccine. There's some data that came out fairly recently, even that in monogamous couples, sometimes what you'll see is that one person will clear it while the other one still has it, and then they'll kind of pass it back and forth, and somebody will clear it and then reinfect and then clear it and reinfect. And vaccination, again, because of its really robust immunogenicity, can stop that cycle. So even people who are in monogamous relationships may still benefit from vaccination. The other thing that you will see, given how good of a vaccine it is, there is talk about switching how we approach people. And so NACI has put out a recommendation to consider single dose vaccination under 15 and 2 doses over 15, but still offering 3 doses in high-risk patient populations, such as immunosuppressed individuals. As a province, we've decided so far not to adopt that. I personally don't think that the evidence is good enough to say, yes, one vaccine is okay for everybody. But I think we're starting to see evidence that one vaccine is still good. One vaccine is still better than nothing. And so if you can offer one vaccine to somebody and they don't come for anything else, I think you've still really done some good. And so I think that evidence is still valuable, but maybe not where we want it to decrease access to vaccine yet. So please vaccinate everybody. No need for boosters. It's a really solid vaccine that prevents cancer. Okay. We're doing a vaccination webinar. If you would like to hear me rant about vaccination more later in the fall, please come. Okay. And so this is until next time, because I have no doubt that I'll come back and talk to everybody again as we move forward with primary HPV testing, the vaccine webinar. I love talking about HPV, so there's lots of opportunities. And if there's any questions, we're going to use the Q&A now. So I'll mute myself and let Donna do some talking.
Right. Thanks very much, Dr. Kean. Just always interesting. I learn much every time I hear you speak. So thank you very much for providing all this information for everyone. As noted, we are moving into the Q&A. There are some questions already there. Thank you so much, folks, for populating as we go. And so I'll be reading through those so that Dr. Kean can collect her thoughts, and Laura too, if applicable. one thing, and I think so far we're looking okay, but just a reminder not to disclose any patient health information when you're putting there. Don't give a specific case example. Just in terms of we're just not wanting to violate FIA in these questions. So I think right now people have asked a general question, which is like a disguised question, which is very helpful. So the two people we have, Dr. Kean, who you've been hearing from, the medical lead for CervixCheck, and Laura Coulter, who's the screening program manager for CervixCheck. So welcome, Laura, and we will start having a look at this. I'm going to actually start with, there was a question that was put in the Q&A that was also answered, which was so that folks can see that one. And the question was, does CancerCare Manitoba have a patient resource that primary care providers can use to discuss HPV triage? And the person asking says they're worried about that patients may still want or ask for frequent PAPs or colposcopy referral despite a negative HPV test. So Leslie put a link in there about, in there, if you look on our website in the screening under CervixCheck page, you'll see a resource entitled HPV Triage for Healthcare Providers. So just would do that. But the person followed up, and I'm just going to read this. It's to make sure that we're there. Leslie, thanks for providing that link. The key messages, though, don't provide information as to why those with ASCUS or LTIL without high-risk HPV do not need repeat PAP or colposcopy referral, and that routine screening will suffice. And so just the suggestion that maybe that's something to consider adding. So just wanted to comment on that. We've got a bundle of questions, but if Sarah or Laura has a quick comment on that, or just note it and we can move on.
I get this question a lot. And so I think, as a primary care provider, just knowledge of the biology of HPV and providing that reassurance. I mean, yes, we have those resources as well, but there's nothing more valuable than talking to their primary care physician and hearing from them that you're not worried. And so, this is why I talk so much about the biology of HPV and stuff every single time I give a talk, because there's a lot of people that don't understand it. I work with gynecologists that don't understand it, and it is complicated. And so if you can confidently say to your patients, I'm not worried, and here's the reason why, this basically says you have no risk, then I think that's going to be the most reassuring thing. I mean, I've got tons of patients that come to see me for a cancer, and we're talking about big surgery and chemo and stuff, and they're like, can I just talk to my family doctor? This is what I need to do. And I think the value that you guys offer to patient care and reassurance cannot be undersold. So I think that's going to be the best way to address the concerns.
Yeah. Thanks very much, Sarah. I think it is, the role of primary care providers in patients' confidence and belief in what they should do is absolutely huge. The research shows it time and again, and we see it in practice every day. So thank you for everyone for your support. So we're going to start with a question actually on HPV vaccination. And the question is a big barrier to HPV vaccination in practice, in this person's practice, are the parents of preteens or teens thinking vaccinating their kids will somehow give them the idea that they can have sex whenever with whoever unsafely, or even having sex before marriage. The person is from Southern Health region where religion is a big thing. What can we say to those parents to increase vaccination rates?
Again, I think the best that you can do is provide education, and in people who are strongly anti-vax, there's not going to be a lot that you can do to convince them otherwise. What you can do, though, is provide education to the patient, who is the child, the age of consent in healthcare can vary a little bit. And I think that, again, you guys know your patients better than I do, but if you had a 16-year-old who was worried and hadn't had sex yet and says, I want the vaccine, but my parents don't agree with this, you can provide birth control to them. Why can't you provide a cancer vaccine to them? So, sometimes the parents aren't going to be the person that you're going to get through to, that it's the patient themselves. But all you can do is provide education and try not to try not to refer to it as a sexually transmitted virus. I like to say things like skin to skin contact. Everybody has this. This is a cancer vaccine. And sometimes that helps shift the conversation. But you're right, there's a lot of stigma associated with HPV. And even cervix cancer is a sex cancer sometimes. And it's something that we all need to work to overcome.
Yeah, thanks, Sarah. And I would also really recommend everybody mark the vaccination webinar in their calendars. We've been already talking a lot about how to frame the conversation, and there's some work on some really good information and videos and brochures and things like that that try to make the case without it's being sensitive to the fact that there are some concerns in the population about what the messaging is behind a vaccination. The next question is the ASCCP recommends 3 consecutive negative HPV tests after LEAP, and the recommended surveillance includes annual testing until these 3 negative results are achieved, followed by a 3-year interval testing for at least 25 years. Can you comment on that, Sarah?
I can. I mean, I fundamentally don't agree with it, and I think that sometimes we have to question why the Americans do things the way they do it. But there's lots of data that says that even a single test is reassuring, and I don't think that is absolutely necessary. I think what you will see when we move to primary testing is going to be still a decreased interval for those who have had high-grade dysplasia, similar to this with a 3-year interval. But I think 3 consecutive negative HPV tests honestly is excessive. And I'd have to go back and remind myself of when they published that guideline. I feel like that was earlier in kind of the course of them moving to co-testing as a strategy, but don't quote me on that. So Heather, I'm happy to chat with you offline about this, and if you want later.
Right, thanks. Thank you very much. Okay, so the next question, in the stratification of the recurrence of HPV after colonization, we see that at 8 years or so, the recurrence is about 1.3%, but then at 10 years, recurrence spikes. It almost appears to surpass the positive line. And just wondered if you could comment, is this accurate, or how do we interpret this?
HPV, is this, I think this is the one that you're referring to. And at this end here, I don't think this is a spike. I think this is just kind of where the end of the table went. I don't think that this is really shooting up to here. I think this is just kind of how the computer program likely plotted it, although Donna probably knows more about stats than I do for sure. I suspect that if you plotted this out more towards the 14 years, that this would just kind of continue like that. So I don't think there is a huge jump in the spike there.
All right, thanks. So we'll stay tuned. I think as we get more years of follow-up, some of these trials we may be able to get some updated information. I'd be curious as to how the people coded their end of trial experience, which might be a feature there too. So thanks. All right, the next question. If there's a history of high-grade dysplasia and the person needs annual screening, up to what age for life? Until age 70? What's the guidance?
Yeah, nobody knows the answer to that question. And I struggle with this, especially, if you do a LEAP in somebody who's in their 20s and you're like, well, you need a PAP for the rest of your life. This seems excessive. And so I think this is where common sense has to prevail. First of all, once we transition to HPV testing, it's going to be hopefully a little bit more clear and less frequent, because we will, I think, be able to stretch that out to every 3 years once you've got so many reassuring negative tests. 70, I think, is reasonable if you had your LEAP in your 20s, but if you had your LEAP at 65, then I think, again, you need to consider where is the risk. The other thing that I think gets lost in all of this is screening really should be offered to people who stand to benefit from screening. And so if somebody is 68 and has multiple comorbidities and is bedbound and you think is only going to live for another year or two, they don't need to be screened. Even if they're technically 68, they're not going to live long enough to benefit from a screening program. And so that's really why 70 is the cutoff most of the time, is because statistically, again, if you look at that graph of HPV, if a 70-year-old got a brand new HPV infection at 70, they're not going to live long enough to die from cervical cancer 20 years down the road. And so if you keep that in mind and frame decision making around that, I think, if somebody is healthy and has a reasonable chance of living for, 10 or plus more years, that screening might be reasonable. But 50 years of negative, if you had your leap at 20, is also probably enough. So there's no absolute textbook answer there, though.
All right. Thank you. So the next question is you talked about the PCR test, and is the PCR test what they're using in Ontario, and as they no longer complete routine pap smears?
So I think you're referring to an HPV test, and yes, so Ontario very recently, I think in March actually, transitioned to primary HPV testing. PEI has done it and BC has as well, and that's what our goal is going to be primary HPV testing. So everybody who presents for cervical cancer screening is offered a PCR-based HPV test. Right now, we're kind of doing this hybrid system. And so what the test of cure that we'd be talking about here is essentially the same HPV test. And just the other thing that I didn't mention in the presentation is be careful how you use the language, right? HPV negative doesn't mean they don't have HPV. It means they don't have high risk HPV. The only thing we're testing for is high risk HPV. Chances are they probably still have low risk HPV because everybody has that.
Yeah, thanks for that clarification. And yeah, it's definitely where we would like to go. This is a first step of using the HPV testing for the in the colposcopy setting. All right, so the next question, if someone has a history of HSIL seen by a colposcopist and discharged, but has not had follow-up cervical screening in more than 8 years, and they're currently pregnant, should they have a pap test in pregnancy?
Absolutely. There's no contraindication to pap in pregnancy. It is completely safe to do. Somebody like this is high risk of having still high-grade dysplasia, and they need a pap. If they're over 10 weeks, you technically can't use the little broom, so it should be done with a spatula. And please indicate that they're pregnant, because especially at more advanced gestations, decidual reaction can look dramatic. But absolutely, please pap people in pregnancy if it's indicated.
All right, thank you. Okay, quick question. Is there a time limit between doses of HPV vaccines to consider 3 doses to be complete?
Technically, it should be given at 0, 2, and 6 months. But again, the immunogenicity that we get from this vaccine is outstanding. And if somebody has a prolonged gap, you do not need to restart the series. You just pick up where you left off. So if they had 1 and 2, and then 2 years go by, you can sure give them number 3, but you don't need to start again.
Right.
It's a really good vaccine.
Yeah, and that's good to know. So it doesn't send you back to 0. So, okay, will the algorithm that has been presented, will it capture a strain that eventually becomes oncogenic? Thinking about viruses change stuff up occasionally.
I mean, currently our HPV assay, I think, looks for about 14 different strains that have oncogenic potential. Certainly, as literature evolves, I would imagine that the providers of the assay will adapt accordingly. But we don't have a lot of data yet on oncogenic drift or shifting or anything like that. It hasn't been borne out in the literature yet, but I'm sure that somebody who knows a lot more than me will be on top of that.
Yeah, all right. Thank you. So when someone clears their virus infection, do we know for sure that the clearance means for good? Like, can the virus reactivate later after the clearance if a person's immunity deteriorates for some reason?
That's unlikely. I think usually if people clear it, it's gone. For the most part, I mean, it could be latent in the sense that they have no symptoms of infection, no abnormal cells, but could still technically be there. And that's where HPV testing, again, is valuable. But what HPV tends to do is hang out kind of in the cervical epithelium. And eventually, if it becomes oncogenic, it'll actually integrate itself into the host genome. And so that would always be present. You wouldn't have kind of a non-detectable phase and then resurgence, but reinfection is absolutely possible.
Okay, all right, good heads up. All right, next question. Is there a proposed timeline for HPV testing to be more readily available in primary care as opposed to only colposcopists?
I don't know the answer to this. I mean, I'm going to all of the meetings and telling everybody we need this yesterday. But I don't know. I don't know what the timeline is going to look like. Donna, you probably have more insight into that than I do, because I'm just an impatient surgeon who wants it now.
I don't know. I think that's underselling what you're doing. I think what we can say is we are very actively in this space, looking at how we're going to be implementing this. We've got an expert advisory group going, which includes the gynecologist, some primary care representation, and the lab folks. And so how we roll this out is a very, very active area of planning. I can't give you a date at this point, but please be assured that it is very much on our priority list of trying to move this along, which is extremely important for our patients and for Manitobans, and contribution to the elimination of cervical cancer is very obvious. So that's a non-answer, but it's the answer that we have right now. Unless Laura, you wanted to add anything else.
No, I think you said it very well. Thanks, Donna.
All right. Okay. A couple more questions here. How long will the annual cytology be for the high-risk patients before returning to the 3-year screen if it remains normal? Sorry, I may have reread that question. Apologies.
So, I mean, it depends on the high-risk patient. I think, like, if somebody's had high-grade dysplasia and been treated, currently the recommendation is annually, indefinitely, but refer back to the conversation that we had about when to stop. So 70-ish when people would stop screening, but if they just had their LEAP at 65, you may want to continue it for another 5 or 10 years beyond that, assuming their health allows for that to be a sensible decision. Other high-risk patients are highlighted in our screening algorithms who would indicate a need for annual testing. So those are primarily immunocompromised individuals, but you can refer to our screening guidelines for that.
Okay, there's also a question about just clarification, because we might have missed this, but which high-risk HPV strains are we testing for?
It depends on the assay. I think currently we're using the Roche assay, and I always have to look this up. I'm looking at it right now. 16 and 18, of course, are the two worst ones, and they will comprise about 70% of all cervical cancer, or 78% of all cervical cancers. The Roche assay has 12 other types, which are 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, 66, and 68. I never remember all of those. But that is what we test for. So those are the ones, 14, that are most likely to cause cervical cancer. And that would probably capture like 98% or something like that.
Hi, sorry, I just wanted to jump in for just a second, if you don't mind. It's in the interest of time and the group that we have here, I just wanted to mention that those providers who are requesting screening histories for their patients, I want to make sure that you're aware that your test of cure result is not going to show up in a cytology like you normally would see your HPV triage would be showing up. It would be showing up in the colposcopy portion of the screening history. So it will be listed in there that a test of cure has been performed, and it will indicate the overall result and whether a strain was existing there. So just to make sure everybody's aware of that.
Yeah. Thanks very much, Laura. I think it's really important, important note where to find this information in the charts. Okay, so a couple of things. First of all, thanks, a shout out to you, Dr. Kean, about this, and also a note that if there are, from the screening program, folks, that if there are any primary care providers that want to help with HPV implementation, we're seeking some feedback. So please reach out to us. And then the last question that we have time for today is why are there age parameters on the triage HPV testing for ASCUS and LSIL results?
Again, I'm going to refer you back to my favorite graph. I think it's still showing here. Basically, we don't want to know somebody's HPV status when they're 21, because guess what? They probably have HPV. And so, we don't want to know here at all. We want to know if somebody still has persistence of HPV once they start to get into this plateau of the curve, because those are the people that we think are at risk. But somebody who is 21 has a mild abnormality on their pap, 100% they have HPV, but 90% they're going to clear it on their own, and it's never going to be clinically significant at all, even if it's high risk. So we don't want to know, because then they'll all come to my clinic.
All right. Well, so I think we've come to the end of the questions. Folks will see that there's a 3 still in there, but it's because we're doing our shout out to thanks for the question, the Q&A period, and the primary providers. Welcome to join and the follow up on the HPV triage resource material. So we've covered those, just so you're assured about that. Thank you all for attending. Thank you so much, Sarah, for the presentation and sharing the information. Laura and team for making yourselves available and for supporting this session. If you do think of any more questions after the webinar, please feel free to email us with them. And the email will be screening@cancercare.mb.ca, which is now on your screen. And if you email them, we will get back to you in a timely way with an answer. And because we are really seeking feedback and wanting to make sure we are resonating with you, we will be sending you a short evaluation after the webinar. The link will also be provided for you to generate your own certificate of participation should you need it for continuing education points. All right, so thank you all. Wishing you a good day and take care.